The topic of this discussion and presentation will be counseling and related matters. And so this is going to begin the introduction to the requirements of the federal rules for counseling. When we get into the state law, there is also additional rules that clarify and give you some guidance as to what these mean. At the end of the presentation, the student should be able to understand, discuss, and apply OBRA 90 requirements to pharmacy practice, and we'll soon discuss what OBRA 90 is. In addition, you'll also talk about some certain circumstances that apply to pharmacy practice in different settings. So OBRA 90 refers to the Omnibus Budget Reconciliation Act of 1990, and you actually have an OBRA of every year that we have a budget, which is every year. But this one actually dealt with some things that deal with pharmacy, but not so much pharmacy as it dealt with things that actually dealt with big pharma or pharmaceutical companies, dealing with reimbursement and some other stuff. However, one of the things that it did do as a side note was it altered some rules in regarding of Medicaid. And we'll talk about those slightly later. Prior OBRAs, the first one in OBRA 86, created Health Insurance Transferred, and it was a consolidated Omnibus Budget Reconciliation Act, and thus COBRA 86. So when you hear things such as COBRA after you leave one job and move to the other, this is actually what the abbreviation stands for, which has nothing to do with the health insurance company, but it was actually part of the COBRA 86 bill. Interestingly, one of the other things that they took up in 1987 was the regulation of psychotropics in nursing homes, as it deals with reimbursement for those nursing homes. So frequently we're going to see things tied to reimbursement that appear in the Omnibus Budget Reconciliation Acts, but that don't necessarily belong there and probably should be in other things so that they're easier found. So OBRA 90 set up 3 new requirements in regarding to Medicaid patients. Now, all of these rules really only dealt with Medicaid patients. However, each of the states then decided to expand those policies to all patients receiving pharmaceutical care in their states. So these deal with drug use review, counseling, and patient medication histories. So it's important to remember that prior to these becoming rule in 1990, that these were not required, and in many states there was no regards for medication histories, for counseling, and those type of things. So what did this do? Well, the first thing that's set up in the drug use reviews are 2 different types, a retrospective and a prospective. The retrospective drug reviews are usually done by the Medicaid administrator or whoever it is that runs the Medicaid drug reimbursement program. That is one of the roles of our Medicaid office here at ULM, is that they are the Medicaid administrators and do retrospective drug reviews. The next one is actually that is to be done in the pharmacy, and that is the prospective drug reviews. A prospective drug review usually deals with a per patient basis and is done at the time of dispensing. And so the different things that you're looking for under the prospective drug review according to OBRA 90 is first off therapeutic duplication. So this is where you start seeing all your software warnings if you do work in a community pharmacy or in a hospital pharmacy that deal with, and you'll see many of the exact same words, because pharmacies are going to be required, if they bill Medicaid and now Medicare, to fulfill these, and actually many other insurances now use the OBRA 90 requirements. So therapeutic duplication deals with multiple agents for either the same indication or from the same class. So 2 ACE inhibitors, 2 statins, or it could even be just an ACE inhibitor and a beta blocker, since they're for the same therapy. Drug disease contraindications deal with pregnancy and Accutane, along those types of things. Drug-drug interactions, which including OTC, and that's why frequently whenever you see the patient registration sheets for major pharmacies, they ask what OTC medications the patient is currently taking. And these are difficult to maintain since the patients change on a frequent basis. However, that's one of the things that you must document that you have at least attempted to do. Prospective drug reviews also target incorrect dosage or duration of treatment. If the prescription's for a hypertensive medicine for 7 days, obviously that's not long enough to actually treat hypertension. Drug allergies is obvious, and they must be documented that you've at least attempted to obtain the patient's allergies, or that they have no known drug allergies in KDA at that time. And then lastly, clinical abuse. When you think about particular agents such as hydrocodone and other controlled substances, or clinical misuse, which just means non-compliance or over-compliance. Another object that came about from OBRA 90 was the offer to counsel. One of the rules, part of it was that every state must be making their own rules in regarding to the offer to counsel a patient. However, if the counseling must include the following things: the name and description of medication, dosage form, dose, route, duration of therapy, special directions for preparation, administration, or use by patient, and along with these others, including one of my favorites, which is what to do if the dose is missed. We will see pretty much the exact same wording used when we cover the State Board of Pharmacy's rules regarding to counsel. One of the important things to consider is the waiver of counsel. And basically, OBRA 90 realized that a lot of patients are not going to want to talk to their pharmacy. And so what they did, they included the statement in OBRA 90, which is the waiver of counsel, just saying, nothing in the clause shall be construed as requiring a pharmacist to provide consultation. It only means, especially if a caregiver or an individual refuses such consultation, it only means is that the patient must be offered to be counseled. So one of my frequent pet peeves is what constitutes an offer. I've worked in a lot of pharmacies and worked with a lot of different technicians, pharmacists, and clerks. And these are a couple of my favorites that I have. And the first one that I would ask you is, would you like to be counseled? So let's assume that you're a member of the lay public. Does that make any sense as to why is a pharmacist going to be counseling me? I don't need a counselor. I just need someone to give me my drugs and tell me what they are for. Next one that could be used as an example of an offer. Do you have any questions for the pharmacist? Well, does he know who's going to win this Friday's night's game or Saturday's game? Those are the types of things. What does that mean? And how could you make this statement better? And then lastly, and one of the most horriblest of them all, you don't want to wait 45 minutes to have the pharmacist counsel you, do you? And I've actually heard someone say that whenever a patient decided they might want to ask their pharmacist a question. Now, what constitutes an offer is a sticky subject, and you must make the offer, but it does not necessarily say what is the offer. And in some states, different people can make the offer. In the state of Louisiana, anyone can make the offer. In Georgia, only the pharmacist or pharmacy intern can make the offer to counsel. And so that puts different things on the pharmacist and the staff whenever you have those types of requirements. But the question is, did all three of these constitute an offer? Whereas if the patient undergoes some type of harm, can the patient go back and say, I did not understand what he meant, or I was not offered counseling? Another thing that created at this time was patient medication use histories. And the rules must again be made by the state, however they must include these things. And interestingly, the pharmacist's comments relevant to individuals' therapy must be included. Now that's kind of, what does that mean? What if there's no comments? Does that mean no comment? Most of the time you do not see comments, but that should be something that you should consider as you do a medication history as you're working in a pharmacy, is put a comment, reviewed, put a comment, looks like everything is fine. So what impact did OBRA 90 have? Well, OBRA 90 is now considered the standard of practice or proper practice. So the most important thing that you need to do is to document that you meet it. Now this is done through computers, this is done through signatures whenever you go to pharmacies and they want you to sign something. It really bothers me when they say that you're signing to pick up the prescription. Well, when you actually read the document you're signing, it actually says that you were offered counseling and refused. Or even better, it doesn't even say refused, you'll just notice the tech checks the box for refused after you're done. That is really a pet peeve of mine. You definitely don't want to do that. There's a board inspector around. Generally it's $500 per offense. And back in my home state of Florida, it was always funny because I could tell whenever a board inspector was nearby, because our pharmacists and clerks would all of a sudden start offering counseling to every single soul that got near the pharmacy counter. And they would usually sit there, and if you weren't careful, they would sit in the corner and just watch. And I've seen pharmacies fined for 10 penalties at $500 a piece, and these usually not only fine the pharmacy, but they also fine the pharmacist. And so that's $5,000 that the pharmacist is out, which could be done in a busy pharmacy in a matter of minutes. And so it's pretty important that you ensure that your staff are making the offer to counsel, and that the offer to counsel is somewhat reasonable. So these kind of summarize some different things that occur and that surround counseling and some of the other things that we do. And the first thing I want to talk about is the duty to counsel patients. As we just talked about in OBRA, one of the requirements to be reimbursed on Medicaid is to offer counseling. However, the actual duty for a pharmacist to offer counseling and to provide counseling is somewhat disputed. Far more cases in courts have ruled that the pharmacist does not have a duty to counsel. Now, you remember we talked about early in the malpractice section about the duty of a profession or duty and how you must establish that. And in many of these cases that is not established. There's relatively few cases, and the ones that do are usually significant deviations from the standard of practice in regards to pharmacy. The long-standing court rulings still assign the duty to the prescribers, and their feeling is that if someone is prescribing something, they should know everything about the drug and they should be able to counsel the patient. As I mentioned before, few assign that duty to pharmacists, and pharmacies are very much against this duty. Their view is that if the pharmacist becomes responsible for this duty, then the pharmacies and the pharmacist can be sued. And so you'll frequently see major chains arguing against the the duty of the pharmacist to counsel, which is counterproductive to what we want to do as a profession. Liability for drug product selection. This is another place where counseling can deal with, and insurance companies deal along with, because we're dealing with generic substitutions mostly. And the general thought is, as long as the pharmacist follows the state rules, all is fine. However, it is important to inform the patient of the substitution or of the potential substitution. However, and then if you don't do all that and you for some reason don't follow all your rules, no protection is granted through the substitution law if it is not a sanctioned switch. And so you are fully liable, you yourself, not the physician, of any damages that occur because you took it upon yourself to deviate from the standard of practice. Another thing, minimizing liability for product selection, and this kind of deals with when we're talking about some of the product selection about AB rating and all that. Of course we're protected. But what happens whenever an insurance company states that lovastatin is not covered? They want you to contact the doctor and switch it to simvastatin. Well, the question is, who's responsible if the patient then has an adverse reaction to the simvastatin? Is the physician, is the pharmacist, is the insurance company? Well, the answer is generally never the insurance company, because once again, the patient can still buy the lovastatin. They're not denying care along those lines. And most of the time, the pharmacist is not liable for anything. Now, the case in point where that might be different is if you're switching from one agent that does not have drug interactions, then you tell the doctor that they need to switch to another agent that does have drug interactions, then you could be somewhat liable for those drug interactions if that prescription is then filled. But most of the time, the courts still rule that it is the responsibility of the physician or prescriber to denote what the patient is on. Case law here is thin. There's a couple of small cases that deal with whether or not the pharmacist who initiated is irresponsible, and in the past they have not been. And the courts have ruled that in the end, who makes the final decision, aka the prescriber, is the one to blame. Lastly, that I want to break up very briefly is clinical pharmacy liability exposure. And this I see very much in the same way as insurances. Clinical pharmacy usually makes recommendations, or they do a certain switch, such as a vancomycin dose or generic substitution, according to a policy that has been approved by the hospital or wherever they are. And so most often, though there's very little court cases dealing with this, the fault lies with the prescriber or the policy. Now then, the fault, once again, the place where the pharmacist can get in trouble is if they deviate from what the prescriber said, or if they deviate from what the policy said and decide to go off on their own and do whatever it is that they feel like they want to do. And with that, what I want you to take away is to be familiar with what OBRA 90 is, what the impact, to be very familiar with what the requirements for counseling, medication histories, and therapeutic drug monitoring or prospective drug monitoring is. And with that,